Welcome to the 5th Annual Lady Marilyn Fioissac Memorial Lecture. It's hard to believe that it has been 5 years since our inaugural lecture. 5 years since we took the decision to honor our esteemed Lady Fioissac, who served as resident tutor of the former School of Continuing Studies of the University of the West Indies from 1982 until her retirement in 1993. During her tenure, Lady Fioissac worked assiduously to ensure the provision of academic administrative support for students following the UWI's Challenge Examination Program via its then pioneering teleconferencing system, thus helping to lay the foundation for what would later become the UWI Open Campus, a campus which, via its modernized online platform, now has the ability to meet the needs of thousands of students across the region. We remain forever grateful to the Fioissac family for allowing us to keep Lady Fioissac's memory alive and for always being in attendance at our events. Over the years, we've had the pleasure of hosting a number of excellent lectures in Lady Fioissac's honor. We believe that she would have enjoyed all of them. Lectures which reflected areas that she either excelled at or would have had an interest in. Some of you may remember that we had Dr. David Williams, a Harvard University professor and a native St. Lucia, join us with his lecture, the very first one, Sharpening Our Vision for a Well-Educated and Healthier Society. The second one was Professor Tilakso with his intriguing Show Me Your Skin and I'll Tell You Who You Are. Sir George Alleyne followed, the Chancellor Emeritus of the UWI, with his Of Flesh and Frailty and What the Lady Would Say, a lecture so well crafted that you could almost feel Lady Fioissac's presence in the room as he addressed his concerns to her. And last year we were honored to have Dr. Diane Douglas's thought-provoking lecture, Who Am I? Embracing the Self and Answering the Call. We know that this year's lecture will be equally engaging, and we look forward with great anticipation to Professor Clement's presentation. If one does but a cursory online search, a dizzying array of information regarding cancer therapies using herbs and plants presents itself. For the majority of persons like myself, unschooled in either traditional medical approaches to cancer or alternative ones, trying to understand the many options available for treatment is simply overwhelming. Yet understand we must, because as noted in Professor Clement's lecture abstract, cancer is a major cause of mortality worldwide, and in the region, it is the second most common cause of death. He goes on to note that with heightened awareness of health and wellness, many persons nowadays are becoming more involved in self-care, using natural options to prevent and treat disease, a move supported by a multi-billion-dollar herbal and supplement industry, which supplies thousands of products to the market, but with little regulatory oversight. The conundrum is that while patients often believe that herbal medicines are highly effective, sometimes more so than conventional ones, the doctors charged with their care, even those with a relatively high level of acceptance, are too often themselves hindered by a significant lack of knowledge of herbal medicines. So enter Professor Clement. And tonight's lecture, therefore, will explore the evidence available to determine whether or not these interventions work to prevent or treat cancer, and will also seek to provide the requisite information to allow for informed decisions regarding the use of herbal remedies, functional foods, and dietary supplements for the prevention and the treatment of cancer. His presentation will no doubt be followed by the usual excellent post-lecture discourse that the UWI is well known for. And so, it is with great pleasure that I now call on our very own Dr. Gilbertha St. Rose, herbalist, integrative healthcare specialist, and managing director of Eden Herbs, to introduce our guest speaker.
So I'll go straight into the presentation of my dear colleague, Professor Yuri Clement. I am so proud to present him to you and to present this topic, do herbal remedies, functional foods, and dietary supplements work in the treatment of cancer? And what you'll be getting here, it's really the sort of evidence base, the science that I know my colleagues love so much. So Professor Yuri Clement earned his BSc degree in chemistry at the University of the West Indies and started work as a laboratory technician in the pharmacology unit, Faculty of Medical Sciences at the University of the West Indies, UWI, in Trinidad in 1991. Following completion of his training, he did his PhD in pharmacology at UWI. He pursued the Royal Society, that's the UK Academy of Sciences, and the Wellcome Trust postdoctoral fellowship at the University of Liverpool. On his return to UWI in 2001, he started his academic career as a lecturer in pharmacology. Since then, his research has focused on herbal medicine use and drug therapy and disease control in diabetes and hypertension, two very common and important disease entities here in our Caribbean region. On his return to UWI in 2001, he started his academic career as a lecturer in pharmacology. Since then, his research has focused on herbal medicine use and drug therapy and disease control in diabetes and hypertension, I repeat. Several surveys were conducted on the use and perception of herbal medicine use among patients attending public, primary, and healthcare clinics. Herbs used as wild onion, and you can read your botanical names, your herbs for asthma, herbs for cleansing, and I was very pleased to see that he did research too on our very own shining bush, Zeb aqueous. And Zeb aqueous, you'll be happy to know that you can get it in some dishes in the hotel as part of a salad. And this Zeb aqueous is shining bush. It's also called inflammation bush. And it is very good as a blood cleanser. So I was very happy to see that because I'm really trying to get persons to start using shining bush again. And everybody should have shining bush at home and put it with the lettuce on the plates. So it was also found that many patients combine herbal medicine with conventional medicine without informing their doctors. And this is what I have been pursuing, integrative medicine, because most patients, they integrate anyway. They will take herbs and they will take the medication and they're quite confused as to what to continue with and to what to stop. So it is good and great when, our Ministry of Health will embrace and realize the importance of educating our people as to, what to use with what and what to use and what not to use. It was also found, I will repeat, that many patients combine herbal medicine with conventional medicine without informing their doctors, and this is research that Professor Clement did by actually going out in the field and getting the data. And it's without informing their doctors. Now, some, if they attempt to inform their doctors, they know what sort of response they might get, so they just don't tell. And this is very unfortunate because sometimes the doctors can learn. And this is how I started learning when I came from my studies at University of the West Indies, talking with my patients, and they were telling me about the herbs that they were using. I say, I want to know about these herbs. And this is why I did it on my own to go and study. And now I can be proud to be an integrative healthcare practitioner using the herbs with conventional medicine, which I continue to use, and our conventional medicines have their own place. So it's important to know that, these patients are combining and unfortunately scared to inform their doctors. Most patients believe that herbal medicines were highly effective and sometimes more so than conventional medicines. Likewise, doctors at public healthcare facilities have a relatively high level of acceptance, and that's good to know. There are some doctors who are willing to know, but with a significant lack of knowledge of herbal medicines, and because they are not being trained in the use of herbal medicine. I'm happy to know that in universities like in Germany, you will not graduate with a medical degree if you have not done training in herbal medicine. And I like that trend now where, herbal medicine training is, an essential part of training in conventional medicine. A landmark island-wide survey in rural communities in Trinidad highlighted relics of traditional concepts and terminologies of health and disease, such as the use of verven, and some of you know our verven lachewat. Verven lachewat, a herb which I use in my detox purifier and tonic, and Professor Clement has done the research, and in fact I think he has some GPs in Trinidad working with him on the use of this verven, lachewat, tachytopheta, gemetsensis. So it is good that gradually our doctors are getting involved in the research in herbal medicine. And here, even in Trinidad, they have the term of cooling, which is the cleansing, the detox, and this is a traditional name we have for detoxing and cleansing. And even in Trinidad, where there is a Creole heritage, they have this term of cooling. And turmeric, everybody's into chichima these days, curcuma, and Professor Clement has done work on the curcuma longa, and also the afterbirth, Carilla, Cerasee, Momordica charantia, very well researched. And, I want to tell you, when we had our first workshop on herbal medicine in the Caribbean, we did it because we wanted to restore our Caribbean heritage. We found that people were coming here, taking our herbs, taking it overseas, and packaging it and bringing it back to us. And this is the case here of the Momordica charantia, which is the Cerasee. So some products that were brought back to us in lovely packaged bottles had Cerasee in it, and we have Cerasee growing all over the place. So it's high time we utilize our own Cerasee, but of course, the patients need a direction as to what amounts to take and when to take it for how long. So Professor Clement has done research, and there has been lots of research done on Momordica charantia for womb cleansing and other studies. Gros Popon, a favorite of Laurent Jean-Pierre, who I saw coming here, is one of the herbs that Professor Clement has researched on as well. So recently, he completed surveys on patients' knowledge, attitude, and behavior regarding marijuana use for cancer and glaucoma. And the cannabis is very topical now, and it's good to know that UWI and Professor Clement have really gone out into the community, checking the knowledge and attitudes and behaviors of patients on the use of the marijuana for cancer and also glaucoma. Glaucoma, well known for 40-odd years. Professor Manley West has proven that it works for glaucoma. Glaucoma, which is a leading cause of blindness in the Caribbean, can be prevented by the use of cannabis. So one day, we will be able to help our patients, prevent them from getting blind just by using medical cannabis. And it's good Jamaica has taken the step forward, St. Vincent has taken the step forward, Antigua, and St. Lucia is still working with the commission to make it happen. But, Professor Clement will tell you, since he's talking cancer today, I'm sure he'll tell you about what he has discovered on the use of cannabis in cancer treatment. As a form of public education, he has written over 50 articles in the Daily Express newspaper in Trinidad, which critically assessed the clinical evidence regarding herbal remedies and dietary supplements. And education is part of what Professor Clement is doing as the outreach of UWI, and that's very good. And he has lots of articles that testifies to that. Professor Clement is actively involved with the long-standing Caribbean White Network of Researchers, which is called TRAMIL, Traditional Medicines of the Islands, which has developed a herbal pharmacopoeia. So, in case Professor Clement doesn't tell you enough about TRAMIL, because after 32 years, TRAMIL, and please check us online, tramil.net, called Traditional Medicines of the Islands. It was started in 1982, and it's 23 countries in the Caribbean, French, Spanish, and English. We work together. It's a program, a network of applied research for traditional popular medicine in the Caribbean. It aims to rationalize health practices based on the use of herbal medicines. And, we've been battling along with this work for all these years, and, it's not known enough, all that we do. Now, in our audience tonight, we are so very proud to have a TRAMIL team. So coincidentally, we have the GEF, which is the Global Environment Fund, just having funded a project to work on a national medicinal plant garden at Mon Repos in Micoud, St. Lucia here. And Dr. Guido Marcel, if you please stand. Dr. Guido Marcel is a consultant who has been brought over to teach permaculture and to help to design that national medicinal garden. And Dr. Marcel is a pharmacognosist. I didn't learn that term till into my adult medical life. But a pharmacognosist is one that, in addition to pharmacology, which is what Professor Clement is doing, he's also versed in botany and chemistry. So it's really the process of looking at, the plants, which is the botany, the chemistry, looking at, the formulation of it, and the pharmacology, the way it works in the body to bring plants to market. So we are very, very proud of our Dr. Guido Marcel, who is part of our TRAMIL team and from Grenada, to be here with us tonight. Also in our audience is our very own Laura Japierre. So Laura is our ethnobotanist, and when we talk of TRAMIL, we have lots of various disciplines in the research area. We have the doctors, pharmacists, we have the pharmacologists, pharmacognosist, botanists, taxonomists, very important, so you identify the right plant. So we are proud tonight to be able to showcase us. So that was us in 2016 when we were on our way to a meeting of our TRAMIL group. We try to meet every 2 years, and if we get more funds, we would meet every year, but at least we do every 2 years. So this is a bit of our TRAMIL, and from the TRAMIL, we have come up with the Herbal Pharmacopoea. So in the Herbal Pharmacopoea, it's a traditional pharmacopoeia, but it's scientifically validated because we go out into the community, we ask the patients what herbs they use for particular conditions, and we have the herbs identified by the taxonomist. Then we take the herbs to the laboratory for the phytochemists to look at the formulation and the phytonutrients in the herb, and then our pharmacologists will look at how this herb works in the human body. So this is a process called validation. So when we check that this herb works that particular way that the person was using it for, then we can say, yay, the folks knew what they were talking about, and most times they know what they were talking about. And our TRAMIL mandate is we don't cover all the diseases, but at least this is, the process that we use. And out of our research, we've come on with the e-book, and we have some on display and for sale outside. So it's an electronic book. It's a CD. You put it in your computer, and this edition has 99 of our Caribbean herbs. You'll get the pictures of the herbs, the description, the phytochemistry, and all this valuable information. So this is the e-book. So this is a TRAMIL that Professor Yuri Clement has been so actively working with for so very many years. So regarding studies in diabetes and hypertension, his recent work explored patients' adherence to drug therapy in uncontrolled disease. An ongoing study supported by the US National Institute of Health as a subcontract award from Yale University aims to determine the genetic basis for non-response to metformin in treatment-adherent diabetic patients. So you can see metformin is one of the conventional drugs, and Professor Clement at UWI, he looks at the herbs, but he also looks at the conventional drugs, looking at the pharmacology and the reason why they might and might not work. So very hard-working Professor Clement.
So today we're going to talk a bit about the evidence, and I'm a scientist, and therefore I look at things through the lens of a scientist: facts, evidence, and proof. I'm in the field of pharmacology, but we know that many drugs that we have, they came from plants. And people today still use a lot of plants alongside their medicines. It's not something that's going to go away. It's something that we have to accept. And therefore, we need to find the proof that what people are using, whether that it works or not. We need to find proof. Because there's some people, what they do is that they exchange. They don't complement, but they exchange. So what they do sometimes is that they have diabetes or high blood pressure. The doctor gives them medicine for their disease. And what they do is that they exchange it for herbs. And sometimes we don't know whether those herbs are working. And therefore they end up in a situation that's worse than where they started. So my work really is to look at that evidence, to see what the evidence is, and to see whether we could tell people what they're using, if it is good, if it's working or it's not working, and steer them in the right direction. And therefore give people the opportunity to make an informed decision of what they're going to do. And cancer, unlike things like diabetes and hypertension, it could kill you very quickly. And therefore we have to be very concerned about what is out there, what people are using, because if you do not take your chemotherapy, you don't have surgery, you don't have radiation, your cancer will progress to the point where nothing else could work for you. And there are some people with cancer who have replaced conventional treatment with herbs and supplements and functional foods, and they get from bad to worse. So my situation here is to say, these are what are people using now, and is there evidence to prove that what they're using, whether it is working or not? Because cancer is serious business. So I'm just going to give you an overview of what I'm going to do. Look at the prevalence of cancer in the world, in the region, and I found something about St. Lucia on the PAHO website. A bit about what is out there. We know that there are many things out there, many herbs. Things like soursop. We have all heard of soursop. Yeah, selenium. Yeah, we have heard of vitamin D. We have heard of calcium. But is there the evidence enough there out there to support the use of these things for cancer prevention And if you have cancer, is it going to work if you have cancer? Is it going to cause cancer to be reversed, or you to stay stationary at one point and it doesn't progress to another point? So what is the best evidence? I'm a scientist, so I have to look for the best evidence. And I'm going to show you what we as scientists would use to provide that evidence. And the evidence really for us is what happens in humans. You test in humans and you determine whether when you test in humans, whether it is working or not. And it's very strict. And I had a talk some time ago about marijuana, and people all want marijuana to be legalized. Everybody must have marijuana. And they say that science is taking too long to give the answer, so therefore, why do we need to do all of this work to find out? But of course, as I said before, some conditions are very serious, and if you don't manage them properly, they progress to a point where nothing would work. So I'm going to talk basically in terms of cancer in three categories: cancer prevention, cancer treatment, and sometimes when you have treatment, you have side effects. So like chemotherapy, for example, you might have nausea and vomiting, you might have loss of appetite, you might have loss of weight, and therefore we need to find the evidence for these. So I'm categorizing them in prevention, treatment, and treatment of symptoms. So that's really where I'm heading. And you will see things like tomato. Yeah? Lycopene is found in tomato, and they've shown, well, it is suggested that lycopene and eating a lot of tomato-based products will prevent you from getting cancer, prostate cancer in particular. And also, if you have cancer, if you take a lot of lycopene or eat a lot of tomato products, then it could prevent you from progressing, and it can actually extend your life. So we're going to look at that. Also selenium, we have heard selenium. Selenium is a big seller, yeah, because we hear about selenium being used for prevention and selenium being used to treat cancer. So cancer today, about 1 in every 5 persons will die from cancer. About 20% of the world population will die from cancer. It is similar in the Caribbean, similar in St. Lucia. The big killers will be lung cancer, breast cancer, colorectal cancer, prostate cancer. In the Caribbean, we have a big problem with men with prostate cancer. Yeah, it's a big, probably, if you put it, the incidence in the Caribbean, it will be probably number 2 or number 3. And in the Caribbean, prostate cancer is very aggressive. I had a talk with someone today, and they were saying that maybe the reason why the survival is so low is because some men don't come forward early enough. So they come forward at a late stage, and therefore by that time it's too late to do anything. That might be an issue, but also in terms of our genetics, we may also have a genetic factor in play in terms of the aggression of the cancer. In terms of mortality, lung cancer is number 1, colorectal cancer, stomach cancer, liver cancer, and breast cancer, in that order. But cancer, there are things that you can do to prevent cancer. Lung cancer, you see, is the number 1 in incidence and the number 1 in mortality. And we know that tobacco smoking is directly linked to lung cancer, so there are things like that you could prevent. Breast cancer is number 2 in incidence and number 5 in mortality. We know that screening for breast cancer, it could be a cure. If you find it early enough, depending on the type of cancer, you could actually treat it. So there are things you can do, and there are also vaccination for cervical cancer, the HPV vaccine that's available. So there are things you can do to prevent cancer, or if you find it very early, to screen, and you can make a difference. But once you have cancer, then you have to treat it. And the conventional way is to the chemotherapy, radiotherapy, and surgery. Those are the key areas in which you treat. So in the Caribbean, it's, as in other parts of the world, it's the second leading cause of death. And by 2030, you will have a 32% increase to over 5 million people. And that is because people are getting older. The older you get, the higher the chances of you being diagnosed with cancer. As well, we live in an environment where there are a lot of stuff in the atmosphere that could trigger cancer. But a small amount of them could be cured if they are detected early and you give adequate treatment. So in St. Lucia, you see that after cardiovascular conditions such as stroke and heart attack, cancer is the number 2 killer, with about 20% of people dying from cancer. So it's a problem. And therefore people want other ways. Some people would prefer not to have chemotherapy, not to have surgery, not to have radiation. Yeah? Some people may see things happening to them and they hide it, or they pretend that it's not there. They live in denial until it reaches a point where it's too late. And sometimes in our attempt to ward off going to the doctor to find what's happening, we do a lot of things. So we go on the internet and we find all these things about the herbs and supplements that we could use to prevent and to fight cancer, the foods that we could use to fight cancer, what we should eat every day. Yeah, carrots and things like broccoli, things like that. The antioxidants, you must take a lot of fruits with flavonoids, and we do all of that. And then, of course, there are the vitamins and the minerals that we also take. And a lot of this is coming from people saying, you know, I use this because it works. So you might know somebody with cancer, and they will say, no, I use this particular thing, and it worked for me. And you now take it upon yourself to say, if it worked for them, it could also work for me. But that is probably the very lowest level of evidence. It's what we call anecdotal evidence. And anecdotal evidence is not proof. It doesn't say anything. All it says is that it works for you. It doesn't mean if with 100 other people, if it works for 100 other people. And therefore what we need really is that we need more robust evidence, more robust proof that what we're using is actually going to work. I'm a scientist, I work in the lab, and I do studies like this. Studies with cancer cell lines, studies with animals such as mice and rats, yeah? And sometimes a lot of information comes out from those studies. So you might have a colon cancer cell line, a breast cancer cell line, a pancreatic cancer cell line. You put them in these little containers, you've nourished them, and then you add your extracts of your plant or whatever you're looking at, and you see that they're dying. And you see that they're dying at very small amounts of this thing. And you say, yes, you publish it, it's on the internet, somebody pick it up, and they say, this is good to treat pancreatic cancer. Yeah? Or this is good to treat colorectal cancer. And this information is just from doing work in our. There are many reasons why we cannot do this. You cannot extrapolate information from a lab into a human. For example, look at this on this side here. Here. These are little containers where the cells are in. You have what we call a medium, and you put in your extract in there. Remember, all of the extract is available to those cells. They're in direct contact with those cells, and therefore you would expect something to happen. If you're taking something by your mouth, it means that it has to be absorbed. It has to go through your stomach, your intestine, go to the liver, then go to the site where it is. So it means that for it to work like this, it means that the amount that you have in your slide, in your tube, must be the same amount that is going to get into the body to cause the effect. And sometimes a lot of it is not absorbed, so the amount that you have to take will be a very large amount. Yeah? And therefore the very large amount could cause side effects that you don't want. So therefore we have to be very careful when we read things about things done in animals and in cells, that we don't always easily extrapolate it to humans. So we have a situation here where we have to convert or translate. We have to translate what we call basic research, and that research is in research in cells and in tissues and in animals, and we have to translate that research into research in humans. Yeah? And that's a big jump. Because you might say, for example, 10 microgram per kilogram or 10 milligram per kilogram in a rat. You convert that to a human, is a very big amount. And some things might work with 1,000 milligram per kilogram in a rat. Convert 1,000 milligram per kilogram in a human. That's in a 70 kilogram human, that's 70 grams or whatever you're given. And that's a lot. And that's why sometimes you cannot take information from the lab and just put it on a human and say, because it works in the lab, it's going to work in a human. So therefore you have to convert this information that we have in the lab into information that is useful for us as humans. And then when you get positive results here, how does that translate into improving health? Because it means now if something is working in a human, then you can now make policy, make guidelines for people to use. So we do have a challenge with a lot of our information about herbs and supplements and functional foods. Because as you see, there's a pyramid of evidence, there's a hierarchy. And the very bottom of that hierarchy is the animal and laboratory research, what I was just talking about. That's at the very bottom. As you go up, you have case reports, and then you have, this is where the bulk of the evidence comes from, case control studies, cohort studies, and randomized controlled trials. That is where the information comes from. Studies done in humans. And studies done in humans, and it's not one, because what we have here in this level here, case report is really a report on one person. These studies here, case reports, I'll go to the next slide. Case reports are what happens in case reports, that you're comparing somebody with a disease, somebody without a disease, and trying to figure out their history and what may be impacting on the disease. So for example, somebody with lung cancer, you have somebody who is equally matched with them, who doesn't have lung cancer, and you try to find out from them what may be the factors impacting on the lung cancer. So for like smoking, the reason why they found out that smoking causes lung cancer is because they found people with lung cancer and people without lung cancer, and they found that people who had a history of smoking, they would have lung cancer eventually. So those are what we call case controls. And there are large studies that will do case controls where you have hundreds of people who have a disease, and then you compare them with what they call control people who are age matched and sex matched. So if it's women with breast cancer, you have women of the same age who you compare them with, and you get a history from them to determine what are the causes of the breast cancer. Similarly, you have what they call cohort studies, and these studies are what we call prospective, meaning that we follow people over time. So if it is that somebody is smoking or somebody is eating a lot of tomatoes regularly, then you follow the people eating tomatoes and those who are not eating tomatoes for a long time, and you see at the end of it, 7, 9, 10, 20 years down the road to see what is the impact of eating tomatoes every day on those people. So it's really, a cohort study is really the reverse of a case control. The case control, you have the disease in front of you and you compare with somebody who don't have the disease. The cohort study is when you know what the exposure is, with and without the exposure, and you follow them over time to see what's going to happen to them in time. And those are the kind of studies that will give us the evidence that these things are working or not. Yeah? And then of course you have the top of the, on a higher level, what we call a randomized control trial. And these are trials where you have a disease or a condition, and you randomly give people either a treatment or what they call a placebo. So a placebo is what people say as a sugar pill, meaning that it looks like, it smells like, it tastes like, exactly like the treatment, but it doesn't have the active ingredient as the treatment. So it has everything except the active component. So what I was trying to explain just now is that the case control, you have people with and without the disease, and then you take a history from them and you draw a conclusion based on the differences in the history. In your cohort study, it's the opposite. In this case, it will be smokers, people who smoke, those who don't smoke, and you follow them over time, and you see what happens to those people. In the randomized controlled trials, you have patients, and these are people who have a condition. So in the case of cancer, it's people who have cancer. Yeah? Then you will give them either a placebo, in this case we say that they are control group, and the treatment. They are randomized, meaning that they have an equal chance of getting either the placebo or the treatment. Then you follow them over time, most times 3 months or more, some could go for a year or 2 years, and at the end of it, you measure the difference between the two. So if you're looking at cancer, for example, you have your placebo, you have your treatment, you give it for 2 years, and you really probably want to measure the survival of those patients, or you want to measure the progression-free survival of those patients, and at the end of it, you will determine whether there's a difference. And this is just to show you what a placebo is. You see, you have 2 tablets here. You can't tell the difference. So the placebo will be one of these, and you don't know which one you're getting. The only people who know what you're getting are the people who are in control of the study. And that is what makes it different, because it means that you don't want the interaction to interfere with the response of the patient. Yeah? If I'm giving you something and you know what it is, you could respond in a certain way, your behavior might change. So if, for example, you are hypertensive and I'm giving you something and saying, I'm giving you this for your blood pressure, you already start thinking, oh, maybe I should start managing my blood pressure better. Yeah, you start doing things subconsciously so that your blood pressure will be decreased. But if you don't know what it is, I tell you, I can give you this, it may have an active ingredient, it may not have an active ingredient, then you don't know how to respond. And really what you're getting is the true effect of the intervention. So, at the end of it, at the top, so you go from case control studies to cohort studies to randomized control trials. And at the top of that, you have what they call a meta-analysis. And what that does is that it really looks at the totality of the evidence. So sometimes you have a study with 200 people, another one with 500 people, another one with 1,000 people. And what you do is that you put up all of them together. And each study, depending on the size of the study, it gets a certain weight of the total evidence. And what you have is something like this. At the end, you have what they call a forest plot. I don't want to confuse you, but at the end of it, you're just measuring what each study is contributing to the total evidence. At the end of it, you get at the bottom here a mean difference. 0 means that there's no difference between your treatment and your intervention. Your placebo and the intervention, that means that is 0, there's no difference. And therefore you can see at the end of those studies, this isn't better than the placebo. But in this particular one, you see that the little box down here is yellow, it is slightly more than 0, and the range is not passing 0. So it means that there's a difference between the treatment and the placebo. And that is what we're going to look at today. We're going to look at meta-analysis that look at the evidence that we have for these different treatments for cancer. So where do you look for that? There's a place online in the US called the Cochrane Library. And there's a website that you can go on, and for almost any treatment in medicine, you can find meta-analysis and summaries of studies that look at the evidence in totality. Looks at all the studies that were done. So if, for example, selenium, there are 10 studies done on selenium, it will take all those studies into consideration to come up with the totality and the evidence to say whether selenium is working to prevent cancer. So you can go and check the Cochrane Library because they have the best evidence. And what the reviewers do is that they go into databases, because as a researcher you publish your work and it has to go somewhere, and there are a number of databases that are available. And these databases would include PubMed, a lot of us probably would know, Medline, Embase, PsychoInfo, CancerList. So there are a number of databases where research will be published and will be resident in. So the reviewers of these studies will go into there, look for these, they have specific search terms, and they will go and they will extract these studies and do their meta-analysis on these studies. The actual language sometimes is difficult to decipher if you don't understand what you're reading. But at the end of each one, in the Cochrane Library, there's a plain language summary. So in this case, they looked at lycopene to prevent prostate cancer, and you can see at the end, they said none of these studies assess prostate cancer mortality. And you can say two indicated no difference in prostate-specific antigen between men randomized to receive lycopene and the comparison group. So normally, when you go in the Cochrane Library and you, for any particular intervention, there's this summary that you can read through and the layman can understand what is being said. So I now start on the meat of my discussion because I've laid the groundwork for what I'm going to talk about, the evidence. The evidence is coming from studies in humans, coming from case control studies, coming from cohort studies, coming from randomized control trials. So my first slide is on lycopene. Tomatoes contain high amounts of this antioxidant called lycopene. And this study was done, well, this review was done in 2011 to see whether lycopene prevents prostate cancer. And all your searches, you know, we will hear a lot of things, right? We hear a lot of things, people tell us a lot of things. But when you search, sometimes you don't find anything. So in 2011, even though we're hearing a lot about lycopene, there were only 3 studies done. Could you imagine that? I'm eating tomatoes like mad because people telling us lycopene is good to prevent prostate cancer. And there's not much for us to rely on. So by 2011, there were only 3 studies done with 150 men, very small number. And the studies were poorly designed, meaning that the numbers were small. Remember, it's only 150 men or so. For you to have a proper study, you must have sufficient number to tell a difference between your treatment and your placebo group. Sometimes studies are not large enough to give you a difference or to tell you whether the difference is really real or not, or whether you're just imagining things. Because sometimes your number is not big enough, you may get a difference, but that difference may not be a real difference. It could be a random effect. So the authors conclude that lycopene, there's not enough evidence to say that it prevents cancer, or it affects symptoms, or it affects the PSA levels in these 150 men. So you now come to carrots. You know, we like to eat our carrots. We say carrots good. You must always eat your carrots, Dr. St. Rose. We tell you to eat your carrots. And they have also shown that people with cancer use a lot of carrots. I did a survey in Trinidad a few years ago in our oncology center, the National Oncology Center, to determine what people use in cancer. And people use a lot of what they call functional foods. Carrots, yeah, garlic, things like broccoli. They make a blend with it, and they swear that these things are working for them. But what I've found is that there's not much information. What I've found is that there are a lot of studies that is showing in terms of prevention. Prevention for breast cancer. In this study, there were over 13,000 people who were followed, either in a cohort study or in case control studies. And they have found that people who had a high intake of carrots, they had about a 30% lower risk of developing breast cancer. Also, this study here, cancer in the urinary tract, also found that increase in carrots also prevented the formation of cancer. And as well, you have with gastric cancer, this meta-analysis showed that increased intake of carrots also prevented gastric cancer. But sometimes it doesn't always pan out, because I will show you later on that even though some studies show that something may be preventing, when you actually have high-risk cases and you have an intervention, it doesn't always work that it prevents progression to more advanced cancer. So we next come to antioxidants. You find antioxidants in a whole set of foods, fruits, especially colored ones with a lot of flavonoids. And the question that the reviewers asked in 2008 was, do antioxidant supplement prevent gastrointestinal cancers? He had over 20 trials, over 200 participants. It's a very large trial. Beta-carotene, vitamin A, vitamin C, vitamin E, selenium, and some of those studies were of high quality. So we're now getting into the realm of where we're really looking at big sample sizes that will give us good information. And what they have found in these trials with over 200 participants, that antioxidant had no effect really to reduce the incidence of gastrointestinal cancers. There was no effect really to reduce mortality either. So even if you were diagnosed with gastrointestinal cancer, it does not stop you from dying. However, they found that this is the overall antioxidant effect, but with beta-carotene, it significantly increased mortality. So there's a negative as well, you see? So it can work against you because beta-carotene with vitamin A and vitamin E significantly increased mortality. So the authors conclude that there was no significant effect, and the evidence is not convincing that antioxidants prevent gastrointestinal cancer. So selenium is one of those supplements and is a mineral where probably the most study was ever done. Yeah? You see, I will show you some data, some additional information. But in this case, we have 83 randomized controlled trials with over 27,000 participants. So now we're getting into the large numbers, and the large numbers is going to give us the evidence that we need to determine whether these things are actually working. And the question was, does increased exposure to selenium reduce the risk of cancer, and does selenium supplementation prevent cancer? The first question has to do with how do you take selenium normally? The second one is when you take it as a supplement. Yeah? And what they have found is that in all these patients, there are 27,000 people who were studied, that there was little evidence that selenium reduces the risk of cancer, and supplementation did not reduce the overall cancer incidence or mortality. In these larger studies, these will be the case control studies and the cohort studies with over 2 million participants. They show that the highest selenium exposure was associated with lower incidence and mortality. And the people who reviewed the studies said that there were major flaws in the method, so therefore this evidence here may not be too trustworthy. They conclude that there is no evidence that having a high dietary background selenium or supplementing selenium would prevent cancer. There was this other study, and it's a very large study that was published in 2010. It was called the SELECT study, Selenium Vitamin E Cancer Prevention Trial. It took over 7 to 12 years. People were followed up for a very long time. There were over 35,000 men in that trial, in that study. They were over 50 years old, they had a normal PSA, and their prostate examination was normal. And they were followed for this long time. They were randomly assigned to 4 groups, 1 group with selenium, 1 group with vitamin E, 1 group with a combination of selenium and vitamin E, and 1 group given a placebo. Remember, we know what a placebo is. It looks like everything, but it doesn't have selenium and vitamin E. And what they found is after 7 years, up to 12 years supplementation with either selenium or vitamin E, none of them prevented prostate cancer, with 35,000 men over 7 and up to 12 years. Green tea. Green tea is the world's most popular beverage after water. Yeah? And in Asia, it's drunk as a custom. And there are a lot of studies. Actually, I had a review a few years ago about green tea and all the effects of green tea. And one of the effects that they said is that green tea will reduce the incidence and mortality of cancer. And in this, another last study similar to selenium, over 1.6 participants, 51 studies, combination of case control cohorts and 1 randomized control studies. And you have a mixed bag. A mixed bag because they found that it may reduce prostate cancer, lung cancer in men, but increase urinary bladder cancer, and they're not too sure about what happens in the gastrointestinal tract. So the authors conclude that the evidence is insufficient and is also conflicting because we're not too sure what is really having a benefit in prostate cancer and lung cancer. We are told to eat our fruits, strawberries, apples, grapes, blackberries, raspberries, full of and in the Caribbean we have other things too, right? But full of antioxidants. But most of these studies were done in the developed world where these fruits are available. So they're really trying to determine whether dietary flavonoids, whether they reduce the risk of colorectal adenoma and colorectal cancer. And adenoma is really the precursor of a cancer. It's not really a cancer, but it probably will lead to a cancer. And what's in this study, they had over 400,000 participants. And what they said is that the total flavonoid intake there's no evidence that it could reduce the risk of colorectal cancer. But there are some of them that they believe could reduce some specific flavonoid that could reduce colorectal cancer. Those are found in dark chocolate, green tea, mangoes, banana, phytoestrogens, soybean, flaxseed, and oats. So the authors conclude that the evidence is insufficient and there is conflicting evidence regarding the use of flavonoids to prevent colorectal cancers. So we now go to vitamin D. And you find vitamin D all over, all right? And they want to find out, the hypothesis was that vitamin D could prevent cancers in adults. And in this systematic review, this meta-analysis in 2014, the question was, does vitamin D prevent cancer? Over 50,000 participants, mostly elderly women, living in community spaces, different forms of vitamin D. And what they found is that there was no difference between people who took vitamin D supplements, people who didn't, in terms of the incidence of cancer. However, they found that vitamin D decreased all-cause mortality and vitamin D decreased cancer mortality 2.5% versus 2.8%. I mean, that's a very, very small difference. It's about 0.3% difference between taking vitamin D3 and not taking vitamin D3 to have this decrease in mortality. So they conclude that there is no evidence that vitamin D either decreases or increases the incidence of cancer. And vitamin D3 decreases cancer mortality, but remember it's by a very small amount. The difference is just 0.3%. And they found that vitamin D3 with calcium increases the occurrence of kidney stones. And there's a much more, and I have quite a few slides about vitamin D, because I think it's one of those supplements that people use a lot to prevent cancer or to treat cancer. And in this study, they really wanted to find out whether the vitamin D status, whether it could predict the risk of prostate cancer and the features of prostate cancer. So there were 19 case control studies with over 13,000 men with prostate cancer and 20,000 men who were controls, meaning that they didn't have prostate cancer, and they compared them to men with prostate cancer. And what they did really is that they measured a metabolite of vitamin D in the blood to determine whether high or low, whether it predicted for prostate cancer. And they found that there was no association with vitamin D status for non-aggressive prostate cancer, but there was some evidence that lower levels of vitamin D status was associated with the non-aggressive type. Again, in this one, they looked at the vitamin D status to determine whether people, how they progress from stage to stage and what their overall survival was in people with advanced and metastatic colorectal cancer. Over 1,000 people who were not treated or had metastatic colorectal cancer, and they were not given this as their first-line treatment. And they were trying to determine what was the association between vitamin D status and overall survival and progression-free survival. And progression-free survival really is the time it takes for the disease to progress. So on entry, most people were deficient, but those who had higher levels of vitamin D, they had improved overall survival and improved progression-free survival. So now we get to the exciting part where they actually give people stuff to determine whether it's actually making a difference. So we continue with vitamin D, and we have vitamin D3, high doses of vitamin D3 together with standard chemotherapy to determine whether it would change the outcome in people with advanced and metastatic colorectal cancer. So you have about 140 patients in two groups. One group given standard chemotherapy every 2 weeks for the high dose vitamin D3. Other group given chemotherapy plus a high dose and standard dose vitamin D3. And you follow them to determine whether the disease progressed. And what they found is that in people with the high dose, the progression-free survival was 13 months as opposed to 11 months. It means that given vitamin D supplementation did not allow progression by 2 months. But you can see that the overall survival was the same, 24.3 months in both. So vitamin D3 supplementation in this group of patients, even though it prolonged the progression-free survival time, it had no effect whatsoever on the overall survival. So all patients, even with and without supplementation, died at the same time. There's another study that looked at women who had high risk of developing breast cancer, people who had mammogram that showed that they were at risk to developing breast cancer, people who had family history of breast cancer. And they looked at 200 women and looked at their status to determine whether that could predict the progression. And they gave them vitamin D3, 20,000 IUs per week. The others was given a placebo, and they were followed for 1 year. What they found is that the change in mammographic density didn't change or did not differ between the two groups. So vitamin D supplementation did not have any effect at all in the progression of the mammographic density. So the conclusion is that vitamin D3 supplementation does not reduce the risk of breast cancer. We continue. And this study was published in this year, 2019, just a few months ago. And they actually looked to see whether vitamin D supplementation reduced total cancer incidence and mortality. In 10 trials, over 6,000 cases, followed up for up to 10 years, and they found that there was no difference even at high blood levels, over 100 nanomole per liter. They consider low to be 30, and these people have over 100, and there was no difference between people with and without cancer. There were 5 trials to look at cancer mortality. There were 1,591 deaths, followed up to 10 years, and they showed that higher levels reduced death. But the conclusion still was that vitamin D supplementation significantly reduced mortality but did not reduce incidence. I think I should correct myself there. This study here showed that higher levels of vitamin D reduce deaths, and this study here showed that it did not reduce incidence. So in this meta-analysis, it reduced mortality, but did not reduce incidence. You all got that? Another study, in this one, you had a large study over 5,000 people. Group 1 given 200,000 IU, which is a massive dose initially, and then 100,000 IU monthly up to 4 years, and the other group was given a placebo. That's a large number of people that we have, 5,000 people. And what this saw is that in that time period, we had 6.5% cancer incidence in the vitamin D group and 6.4% incidence in the placebo group, meaning that there's literally no difference really between the two groups in terms of cancer incidence, and supplementation, even with these very high doses, does not make a difference. So we come now to selenium. Remember we said that selenium is one of the big sellers now, and a lot of work was done. So in this study here, what they did is that the men who had high risk to develop prostate cancer, what they have is what they call high-grade prostatic intraepithelial neoplasm, which is a precursor to developing prostate cancer. So they choose these men here and randomize them because they had high risk of developing cancer, randomized to receive either 200 micrograms of selenium for 3 years, and the other group, placebo, for 3 years. And they determine the rate of cancer developing in these men. And what they found is that selenium did not prevent the conversion to cancer in this group of 400 men with precancerous lesions. Calcium is another supplement that is used, and this question was to determine whether calcium will reduce colorectal cancer or these polyps, which are precursors and could predict the development of colorectal cancer. Over 1,300 subjects given large doses of calcium for up to 4 years, and they found that there was a reduction in the incidence of these polyps. And they're suggesting that this does not constitute enough evidence. Sometimes we have to be very careful with what the authors conclude. Because I would think that with a large study like this, over almost 1,400 subjects, over such a long time, 3 years and 4 years, and there was a reduction, but they still say that it doesn't provide sufficient evidence. So sometimes even in looking at these studies, we have to be careful with what the authors conclude. But I would say that it is sufficient evidence that it is causing a reduction in the incidence. Green tea. We drink a lot of it. And again, they look to see whether green tea can prevent progression to prostate cancer in these men who have these lesions that could lead to prostate cancer. And they had a small group of men, just 60 of them, and one group was given 600 milligrams of green tea catechins. Catechins are the proposed active compounds in green tea. They are antioxidants, and they were given it for 1 year, and the other group was given placebo for 1 year as well. And they found that adding catechins did not prevent the progression to prostate cancer. Tomatoes, lycopene, and the question here was whether lycopene and selenium would prevent progression to prostate cancer in men who have high risk of prostate cancer. 60 men, another small group, Group 1 was given a mixture of lycopene and selenium, and the other group was given placebo for 6 months. And sometimes we have to be careful, because the lycopene selenium group, there was a higher conversion rate to prostate cancer. Yeah, we always look to see that there's a benefit, but sometimes there's a flip side. But then we have to be careful, because it is a small group of men, 60. And sometimes the number of people in the study could determine the outcome. Yeah? Remember you saying that you need to have a certain number to be able to be sure that your evidence and your results are robust. And I'm not too sure whether 60 men will be sufficient. It depends on what they expect. Yeah? Sufficient to make this kind of conclusion. Tomato, looking at progression to prostate cancer. This time they had an even smaller number. And you see the result is different. This time it's saying it does not prevent progression. Whereas previously it says there was a higher rate of conversion. But the difference here is that in this one you had selenium added. So we now come to cancer treatment. We're going to look at the meta-analysis, and there are a number of treatments going around. I don't know if anybody heard of Vichy mushroom. It's very popular in the East, in China, in the Oriental countries, and it's part of medicine, traditional Chinese medicine for a long time. And they have, it's actually in China, there's actually hospitals that would prescribe what we will consider here to be probably bush medicine. There are hospitals there that would prescribe. And the Vichy mushroom has been used for centuries in treatment. So the question here was, does this mushroom prolong survival, improve tumor response, host immune function, and quality of life in cancer patients? There were just 5 studies. The quality was poor. With chemotherapy and radiotherapy, there was some positive response. Without chemotherapy and radiotherapy, it was not the same as when you combine it with chemo and radiotherapy. However, they showed that there was improved quality of life compared to the people who were not given it. And they conclude that there is insufficient evidence to use this as a first-line treatment. But they suggest that it's possible to combine it, to give it as adjunctive therapy with chemo and radiotherapy, because it helps with tumor response as well as stimulating host immunity. Mistletoe is not only for Christmas. It's also used a lot in Europe as complementary treatment in cancer. And there are mistletoe extracts that are used in oncology. In Germany, it's almost side by side. You know, there's homeopathy, and there are a lot of, they accept alternative medicine. And mistletoe is one of those therapies that is used quite often in Europe. So we had almost 3,500 patients. 13 of them investigated survival. Some of them showed benefit. A lot of them showed that there was improvement in quality of life. Quality of life means they're able to function, they're able to move around, they don't have as much pain, as much nausea, vomiting, things like that. They're not depressed. Yeah? They have performance indices improved, and they also have reduction in chemotherapy side effects. It was well tolerated with very few side effects. And they conclude that the evidence is weak to support the use of mistletoe extract, but there's some evidence that mistletoe extract could improve quality of life. So we now come to some clinical studies. PSA. And the question was whether lycopene will reduce PSA levels in men with non-metastatic prostate cancer. A small study, just 3 weeks. And actually, I would say that this is a poor study. 3 weeks is not sufficient time for you to determine whether PSA level will decrease. But I just show it because we go on the internet, we find stuff, and some people pull out some stuff conveniently. Because the result says positive. It's saying that lycopene, 330 milligram of lycopene daily, is reducing PSA, but it's a small number of men, 79 men, over 3 weeks. Normally they will look at the PSA doubling time, and that sometimes that could be a long time. It's not 3 weeks. So we have to be careful when we go online, even with human studies, to determine the quality of the evidence. Pomegranate. This study, on 100 men, done over 4 weeks. You give the juice, a placebo, for 4 weeks, and after 4 weeks, you give them the juice for another 4 weeks. And they said that it had no effect on the PSA doubling time. Another study was a little more men, 180 men, give them the juice, well, ordinary juice, the liquid extract, and a placebo, and you follow them for quite a while to determine the PSA doubling time. And what they found is that there was no effect really, because for the placebo, the doubling time was 15.6 months as opposed to 14.5 months. I mean, it looks like it's different, but it's not very different, because when you do your stats on it, you find out that there's not very different. So the pomegranate juice has no effect really on reducing the PSA doubling time in this group of men. All right, so now we know that what we call in Trinidad hardy, turmeric. It has a compound in there called curcumin, and curcumin is gold, they say. Yeah? And this study looked at whether curcumin could reduce PSA doubling time in men with prostate cancer. 97 men over 6 months given curcumin every day or placebo, and they found that curcumin decreased the PSA doubling time. Decrease. I said increase. Oh, right, sorry. It decreased PSA doubling time. And we come back to our friend, selenium. And selenium, they wanted to find out whether selenium, and this study was done in 2012, whether selenium prevent progression to men with high risk. Almost 700 men. These men, high risk PSA over 4, suspicious examination, and a high rate of PSA increase, but negative biopsy. A low dose of selenium, high dose selenium, 200, 400, placebo, assessed every 6 months up to 5 years. This is our last study. 700 men, up to 5 years followed. And what they found, that there was no effect to prevent progression to prostate cancer in men at high risk. So, the big topic nowadays is marijuana, cannabis. And in some places it is legal, and in some places there are products available to use for certain conditions. And this is one product that is used called Sativex. It's a mixture of THC and CBD, almost equal proportion, and is available as a spray. But it's normally used in people with multiple sclerosis, people who have muscle spasticity, but it's also found use in people with cancer. And they have done some studies with people with cancer pain who don't respond to normal painkillers or opioids. And what this study shown, I think this was in a large number of people, they showed that there was no difference between a placebo and Sativex to control pain. And this Sativex was added on to what they already given painkillers, and this is added on therapy. And they found even adding on, there's no difference between Sativex and placebo. And this other study show the same thing. So you do have side effects to treatment, and marijuana products called cannabinoids, which Sativex is one of those products, they're also used to treat nausea and vomiting induced by chemotherapy. And the question was whether cannabis-based medications are safe and effective to treat chemotherapy-induced nausea and vomiting. There were 23 trials with quite a number of patients, and what they call crossover. And crossover is another design where each person is exposed to both treatments. So they are exposed to the cannabinoids, and there's a washout period, and they're exposed to the placebo. And you compare the results from both. They had low to moderate quality. However, they were not compared with the newer drugs for nausea and vomiting. When you compare them with placebo, more people taking these cannabinoids reported absence of nausea and vomiting induced by chemotherapy. However, people taking cannabinoids, they would withdraw because there were side effects of feeling high, and despite this, people still preferred it over placebo. But when we compare it to the drugs used for nausea and vomiting, there was no difference in the incidence of nausea and vomiting. So they should give them a standard drug for nausea and vomiting compared with the cannabinoids, and there was no difference in the incidence of nausea and vomiting. However, there was a 4-time greater chance of withdrawing because of side effects, and they also had all of these things happening to them: dizziness, dysphoria, euphoria, feeling high, sedation, compared to the standard drug given for nausea and vomiting. And of course, again, they preferred it over the standard drug. So the authors conclude that the overall evidence is low. They found that the design, there were limitations, but they recommend that in cases where people do not respond to the standard treatment, where what we consider refractory, people are refractory, that you can use these derivatives in those cases. But of course, as always, you always need more research. So there are also some studies done to determine the effect of this intervention on treatment-associated symptoms. So in radiation, you can get radiation dermatitis as a side effect of radiation. And this study looked at curcumin, almost 700 breast cancer patients in 2 groups, and they were given curcumin during therapy and 1 week. And in this study, what they found is that there was no effect between the 2 groups for the severity of dermatitis and pain and quality of life. So curcumin has no effect on affecting the severity of radiation dermatitis in radiation therapy. Green tea, while it has any effect on gastrointestinal complications, chemotherapy, nausea, and vomiting is a big thing. There are 42 patients in 2 groups. 1 group given 450 milligrams of catechins for 5 weeks, other one given placebo for 5 weeks. What they found in this study, the small study of 42 patients, is that a decreased radiotherapy-induced nausea, not diarrhea, but not vomiting. And I have this picture here because all of us here would have heard about soursop, Annona muricata. Dr. St. Rose, we have all heard of soursop. And I did a study a few years ago in our oncology center in Trinidad, and soursop was the #1 herb or supplement used by patients with cancer. And a lot of them believe that soursop works. The leaves, the fruit, the stem, the roots, they boil it, they drink it every day. And some of them believe that soursop is as effective as the conventional medicine. But I am on proof and evidence. When I looked, I saw that there were many laboratory studies, and all of them was telling us positive things. So there were animals who they made have cancer, or there were cancer cells in the lab, and all of them were saying that extract of soursop was causing these cancer cells to die. But I looked and looked and looked, and there were very, very, very few cases in humans. And there was not one single randomized controlled clinical trial. Not one. So therefore there's nothing we can say about soursop. Nothing. And it's really anecdotal evidence. I did find one paper that was done in 2014, and it's a case study with one person. Remember when you look at the hierarchy of evidence, cases are at the bottom just after animal studies. So you have animal studies cases right after. Then you have your cohort, your case control, and your randomized control trials. So this evidence for soursop is really at the very bottom. And therefore we cannot really say whether soursop is really working to treat cancer. But this case study is one patient who had breast cancer. She tried many different things. She went through all of the conventional treatment, chemotherapy, radiation therapy, everything, and she was not responding. But while she was doing that, she was taking extracts of soursop. And what they found is that there was no progression of her cancer. But that's just one case. And I was talking to somebody today who is in integrative medicine, and they're saying that these things work. But if they work, it means that you must tell people that they work. You must publish it somewhere so people will know. Why is it that after all these years we're looking at soursop and there's only one case report on soursop? And everybody going around saying soursop good for cancer. And what could happen is that people may believe that it's working, and they may not take what they're supposed to do. They may not take their chemotherapy, or they may delay the chemotherapy. They may not do surgery, they may not do radiation therapy because they're taking a herb or a supplement believing that it works, when there's no evidence to support that it works. Maybe one person may have used it and it worked for them. It doesn't mean that it's going to work for you. That person might be a person who it work for. But if you give 100 people it, how many of them would it work for? But there are things we can do to reduce the risk of cancer, like not smoking, eating healthy. They say breastfeeding reduces the risk of breast cancer. There's a vaccination for cervical cancer. Too much sun, pollution, being active, and also screening for cancer. Those are things that we can do to prevent or detect it early so that we do not progress. So I know that you had a long talk, and I don't know if you remember everything. So I have a little slide here with some points that we can take home, right? The first point that I want to say is that vitamin D, selenium, lycopene from tomatoes do not prevent cancer or prevent progression of cancer. That's what the evidence is saying. I have something positive to say. Vitamin D status may improve quality of life and progression-free survival. Positive. Lycopene and pomegranate, they have no effect on prostate cancer or PSA levels. The evidence for green tea is conflicting. In some cases it may prevent, some cases it might increase, some cases we don't know for sure. From what we know, from the evidence that we have from cohort studies and from case control studies, eating more carrots, not only good for your eyes, but it could actually prevent breast and gastric cancers. That's what we know up till now. Remember, we did look at some studies that show even though something may be preventing, when they looked at people at high risk, it didn't really have an impact. So we have to wait on those studies to determine whether if you're already diagnosed with cancer or at high risk of developing cancer, whether it will stall it or whether it will cause it to be canceled. And my last point is that cannabinoids may be useful for refractory chemotherapy-induced nausea and vomiting. So that's a plus. So I try to put some pluses in there because it may seem as though we have only negatives. But remember, I am the bearer of the evidence. I'm not saying this on my own. I pull from the evidence, so I'm almost like a judge looking at the evidence in front of me and making a statement on the evidence that is in front of me. So thank you for being a very good audience.
No event could ever be successful without the hard work and dedication from a team. So it is with this in mind that I stand before you to present this brief vote of thanks. Firstly, I would like to acknowledge the presence of Her Excellency Dame Paulette Louise, Governor General Emeritus of St. Lucia, and I would like to thank you for gracing us with your presence and for your continuous support. Also, a special thank you goes to Professor Yuri Clement for agreeing to participate in the 5th annual Lady Marilyn Fioissac Lecture. I am certain that the audience enjoyed the information that was presented by you today, this evening, sorry. Also to the members of the Fioissac family. We thank you for giving us the opportunity for us to honor the memory of Lady Marilyn Fioissac and for allowing us to more or less continue this lecture on an annual basis. Thank you for your support. And to the other members of the audience, but I would just like to thank you for taking time out of your busy schedules to come here this evening to gain information on the use of natural remedies and herbs to perhaps eventually help combat this rampant disease of cancer. I know that it has affected a number of persons that we are familiar with, but it is an unfortunate reality that we have been handed.